Voy a hablar en inglés, sorry. Good morning, everybody. Above all, I'm Susan Blank. I'm an assistant commissioner at the New York City Department of Health and Mental Hygiene, and I'd like to thank the Congress for inviting me today. I'm going to talk about ending the HIV epidemic, at least New York City's strategy for doing so. I'm going to cover the New York State blueprint for ending the HIV epidemic in New York State, talk about New York City's HIV/AIDS epidemiology, updated as of yesterday, as a matter of fact, talk about our end of epidemic implementation strategies in New York City, and share some progress to date. First, in talking about the blueprint, ending the epidemic. Really, this was all made possible because of some real community activism who looked across the horizon of what was available in terms of the science. I mean, the science has moved a long way in the last several years. We have the access to effective treatment. We now know that people who are undetectable are uninfectious, and we have access to PEP and access to PrEP. And what the community activists did was look at the science and say, hey, we aren't implementing the science well enough, and with that, and with the engagement of the scientific community, garnered political will that was necessary to create a task force. And that task force sat in 2014 and came up with a blueprint for ending the epidemic in 2015. Here it is being presented by the governor of the state of New York. And by December of 2015, the mayor of the city of New York, along with the governor, made the announcement that they were going to be investing millions of dollars in seeing to this blueprint being effected so that our 5-year plan could come true. So what does ending the epidemic mean? What it really means here is bending the curve of HIV prevalence among New Yorkers. And scientifically, this is estimated to be, this is going to be at the point at which new HIV infections become smaller than the number of HIV/AIDS deaths. And so our 5-year plan has 3 very broad goals. One is to identify persons who are undiagnosed with HIV, and link them to care. Let's try this again. To retain persons with HIV in healthcare in order to maximize viral suppression and prevent further transmission that way, and to facilitate access to pre-exposure prophylaxis for HIV-negative persons at risk of exposure. This point here, for New York State is deemed to be an incidence of 750 new infections per year. In New York City, we hope to decrease our number of infections to 600 incident HIV infections by the year 2020 in a city which now counts 8.5 million people. Realistically, in terms of number of HIV cases diagnosed, that would probably translate roughly to about 1,325 new diagnoses per year. So next, let me tell you about the epidemiology of HIV in New York City. This is our history of HIV epidemic from 1981 to 2016. There are some key events in the history of HIV noted here, which are undoubtedly too small for you to see. I'll point out here that this is where HAART, or highly active antiretroviral therapy, is introduced. This shows you, these bars represent the numbers of people living with HIV plus minus AIDS, and they are represented along the secondary y-axis. Along the primary y-axis are the number of persons who have died with an HIV-related death, and again, with the advent of HAART, you could see a huge decrease. And most importantly, this represents new HIV diagnoses from when we first started reporting HIV by name in 2001, at which time we had about between 6,000 and 7,000 new diagnoses reported per year, to where we are today. And in fact, just yesterday, the new numbers were released, and in 2016, we reported 2,279 new HIV diagnoses in New York City. So that's a really pretty steep decline, and that's what really sets the stage for us. If we look at 2016 as a year and look at who is it that was diagnosed with HIV, I'm going to give you some quick highlights. One that you can see here, this shows you percentage along this graph, and this is different characteristics: gender, age, race, ethnicity, age, borough of the city of New York in which that individual lives, transmission risk, and relationship to poverty. And the things that stand out here is this green bar here, which shows you that almost 80% of our cases are among men. You can see that of our cases, actually almost over half of them are among men who have sex with men here. And they affect disproportionately our non-white populations of Black and Latinos account for about 2/3 of the cases, though they do not account for 2/3 of the New York City population. Most of the cases diagnosed are under the age of 40, and you will notice this is based on, this has not been updated for 2016, but about 80% of the new HIV diagnoses live in neighborhoods that are deemed below the US federal poverty line. So given those three broad goals that I mentioned, this is what we decided to do to implement ending the epidemic activities in New York City. First of all, we realized that, again, there are certain populations that are disproportionately affected by HIV at this point, and number one is to really address the disparities. And in that context, one of the key things that happened was the transformation from New York City's public safety net sexually transmitted disease clinic services to sexual health clinics that can provide a full spectrum of HIV services. This is really something that's really critical, and I had mentioned it to some of my colleagues this morning, is that it represents a real paradigm shift. Because although this is a free public system, this was a system that was really designed for the care of symptomatic sexually transmitted diseases in which people would come in on an episodic basis, and the phrase that we'd use in English was treat 'em, street 'em, 1-2 visits maybe, and hopefully we wouldn't see them back again. The thing that's a paradigm shift is, although we had been providing HIV testing for many years within that clinical setting, is that, and as well as post-exposure prophylaxis, is that this was seen as an opportunity to really introduce HIV services, particularly PrEP, as well as HIV treatment for a largely underserved population that often didn't have primary care, and to use that visit to really get people engaged in HIV care services. The other thing is that the other paradigm shift that this entailed is that the clinicians who work in the clinics known as STD clinics were largely dealing with bacterial infections, not so much viral infections, and in the United States in general, the use of antiretroviral therapy of any sort, whether it's prophylactic or treatment, is usually relegated to the realm of HIV specialists. And now we were saying, no, primary care providers can use antiretrovirals successfully. Other strategies that included the sexual health clinic system, but also the city as a whole, was to really address the delivery systems for PrEP and PEP, to support priority populations using novel strategies, to take New York City's viral suppression citywide from good to excellent, and to make New York City healthcare systems in general, public, private, whichever, neutral to HIV status. Namely, if a patient is sexually active, there is some HIV intervention which is appropriate to that patient, and the primary care interaction should bring this up in a manner that's appropriate to the patient. So how did we start? Well, as I mentioned, last year, actually exactly a year and a bit ago, we had declared that we were embarking on this effort to end the epidemic in 5 years. And the first thing we did, once we came up with our broad brushstrokes of plans that I went through, is we decided to actually treat HIV like an emergency. I know that sounds crazy in this audience because we've all been very committed to addressing HIV. But you know, in New York City, with Ebola, with Zika, with the Legionnaire's outbreaks, we have gotten very accustomed to emergency operations centers and doing things on a sort of cross-agency basis. And we decided to do this with HIV. And so we met as an emergency operations center several times a year and dealt with this as an emergency. And this was because the community was expecting us to move fast. And I'm going to focus a bit on our discussion of the sexual health clinics in New York City. And I'm going to tell you why that was an important place to really put the majority of the effort that we are placing. And part of that has to do with who goes to the New York City sexual health clinics. Actually, the profile is very similar to the profile that I showed you of people who were diagnosed with HIV. In fact, the sexual health clinics diagnose a substantial proportion. This shows you reported cases citywide of a variety of entities: HIV, acute HIV, chlamydia, gonorrhea, primary and secondary, and latent syphilis. And at the sexual health clinics, you will see in green, almost 10% of the city's HIV is diagnosed in those clinics. Almost 20% of the acute cases, of all the acute cases in New York City, are diagnosed in those facilities. So that is an incredible opportunity to jump on people who are newly infected and get them on treatment and get them into care. In addition, we are responsible in the sexual health clinics for diagnosing a substantial proportion of some important sentinel events. One is almost 20% of the primary and secondary syphilis cases in New York City are diagnosed in our clinics, and almost 15% of the gonorrhea cases are diagnosed in our clinics. And why am I calling these sentinel events? Folks, this is the money shot, for those of you who know that term. These are 3 studies that were done by Pathella et al. In New York City, and it was looking at men who have sex with men who are HIV negative to see what happened to them over time using the sexual health clinic medical records, the STD surveillance system, and the HIV surveillance system to get a longitudinal picture of what's going on. And what we found was that 1 in 42 HIV negative gay, bisexual, or other men who have sex with men, I'll refer to as MSM, 1 out of 42 attending the sexual health clinics would be diagnosed with HIV within a year of that visit. If we turn our attention to MSM who are HIV negative, 1 out of 20 diagnosed with primary or secondary syphilis in New York City would be diagnosed with HIV within a year. And 1 out of 15 HIV negative MSM diagnosed with an anorectal infection of chlamydia or gonorrhea at a New York City sexual health clinic would be diagnosed with HIV within a year. So what you saw in the previous slide, the fact that we are diagnosing in those public clinics a non-negligible proportion of those cases means that for those HIV negative men, that is what? That is a PrEP opportunity. And so what did we really focus in on at the sexual health clinics? One is we had been providing post-exposure prophylaxis, and what we were doing was providing just a few days' worth and referring patients on to a provider who could give the balance of medication and do the medical monitoring. Again, these were clinics that were not equipped for longitudinal medical monitoring. But what we've begun doing is we provide the full 28-day course for the individuals when they come in with a history of exposure. We provide the laboratory monitoring. We provide navigation and linkage, and we hope to also initiate them on PrEP. We are also positioned to provide 1 month of PrEP medications for any patient. and as well as spend quite a bit of time. This is, actually, it's not just giving out the medications. In the US, it's having someone help the patient navigate what are the benefits that are due the individual, what kind of insurances need to be applied for, and to make sure that there's a warm handoff to a provider waiting at the other end who can keep that patient in care. Similarly, with our new HIV positives, whether they are new rapid test positives or acute HIV infections, we have begun to provide immediate antiretroviral therapy for those who are newly diagnosed, particularly for those who are treatment naive. We provide laboratory monitoring as well as doing a very white glove hand-holding and assessment of benefits with linkage to long-term care. Other things that have happened with that investment has been a real, reinvigoration of a clinical system that was really seriously eroding over time. For the last 15 years, our public STD, sexually transmitted disease clinic system, had been eroding. Budget cuts left and right, fewer and fewer facilities at which to provide that care, cuts in services, cuts in hours, and of course, cuts in patient volume. What we did was really to use the end of epidemic funds to reinvigorate those clinics, make them places that are destinations for people. We've restored screening services for asymptomatic patients, so you didn't have to have symptoms to show up at a sexual health clinic. Sexual health means that if you don't want to see a provider, you can just drop off your body fluids, we will test them, and you can check the results on your own and come back. We've upgraded for our diagnostics for other sexually transmitted infections. We've enhanced our human papillomavirus-related services. We also, in addition to the vaccines that we had been providing before, namely hepatitis A, B, and meningococcal vaccine, we now provide HPV vaccine within our clinics. And although we had always been providing emergency contraception in our clinics, we have introduced using that emergency contraception visit not only for HIV care, but to introduce quick start contraception for women who wish to get longer term contraceptive services. Most importantly, though, has been the customer focus on this. We have expanded our hours. We've added a whole triage system that includes nurses to help people figure out which services they need. We have a video that loops that explains to people what are the different services that they may wish to avail themselves to at the clinic and to know what to expect at the clinic. We have added patient amenities, which may seem very obvious to some, but gender-neutral bathrooms that are equipped to comfortably self-collect specimens, be it anorectal specimens or pharyngeal specimens. And the big investment was investing in the training of all of the public clinic staff. Specifically, that's not just customer service, that's customer service on steroids. And in fact, we really have spent a lot of effort in training all staff, not just the clinicians, but the front office staff, in being welcoming and affirming to our transgender, lesbian, gay, and bisexual patients, so that this is a place that anyone should feel comfortable seeking sexual health services. And the other thing that was a first is that the clinics as they existed were only really known by word of mouth. We actually undertook our first ever social media campaign to let people know that these services were available and that we were open and welcoming to those who wished to use these services. I'm going to show you some pictures from our social media campaign. This one hopefully is, this campaign was done in multiple languages, English and Spanish primarily. This one asks, I don't know if this translates well to Spanish, does it? Yeah. It does, okay.
Very explicit.
Oh, good. Well, the truth is, one of the things that was really interesting about doing a campaign like this is if you want to promote sexual health in a puritanical country like the US, even though New York City is a fairly, progressive place, getting ads about sexual health into the media, into social media, on behalf of the health department, has been an inordinate headache until ending the epidemic. And I think that finally our government is ready to recognize that people actually have sex. I think that for those of you who are from the government, I don't mean to offend you at all. But anyway, so we had to come out with, we decided that we were going to advertise these clinics. We're very proud of our sexual health clinics. And we had to figure out a way to do it. And we decided that humor was the only way to go. We had gone through various iterations and focus groups, but really by trying to be funny about it, we were hoping we could promote the conversation. And these ads actually were posted in the New York City subways and on the bus kiosks. Let me show you a few more of them. Our tagline has been, "We've got you covered." Actually, I didn't mention New York City has a condom distribution program. Condoms are available free and in unlimited quantities. We provide about 43 million condoms a year. And our catchphrase was, "We've got you covered" for the sexual health clinics, no matter who you are, no matter what you're into. Here are some more. This is my personal favorite. Barebacked. I don't know, does that translate? Yes? Is there an equivalent? No. No? Okay. We've got you covered. And similarly, se te rompió el condón. We've got you covered. This is our second one. This one just came out a couple of months ago. And what we decided to do was take advantage of the fact that most of the people that we were most concerned about attracting are people who tend to text message and happen to love emojis. And the fact is, emojis require no investment in translation. It really does span across the languages. So here are a couple of our ads. You can enjoy your sex life and stay healthy by getting tested for sexually transmitted infections today. And what you have here is a little text. We still on tonight? Does this translate? Come see me if you need help later. And anyway, the point is, whether it's a fling or a serious thing, get tested. These went up in the subways, and what was really amazing, and this is the Spanish version, besides the fact that as a health department, we feel that we need to encourage all kinds of consumption of fruit and vegetables, we also decided that we also were really amused to see that, in fact, there were plenty of older New Yorkers who had absolutely no idea what this was about. And there were newscasters. It was actually a thing that came out on the television news of newscasters going around and asking people of different ages, and they'd show this to like high school kids, younger kids, and they would just look at it and crack up and like couldn't talk. But older folks were a little bit confused. In any case, the point of this was to say we put this out on social media as well, and in fact, we've gotten a lot of great feedback. This one, I love this. I'm just going to read some of this to you. New York City winning. I love this. Ha ha ha. Keep yourself healthy. This is better than the one with the gay 76-year-old model on steroids. Another one. Hey, this is a really great message to the LGBT community targeted at gay men. From the looks of the comments, thank you, whoever issued this message. Copywriting is on point. It's good to know that someone is looking out for us, or at least attempting to. So let me tell you a little bit about our progress to date. So we like to think of ourselves at the sexual health clinics as hubs for sexual health care and for HIV care. And what you can see is, I think of this, again, forgive me that I'm using sort of the American calendar, but we began our work really in 2016. And these represent right around the end of October of 2016. This is end of November 2016, and this was around Christmas time of 2016. And since that time, PrEP navigation, that is, the very engagement of patients in order to get them into a care setting that is appropriate to them for the longer term, we've had over 5,000 encounters. We have provided 28 days of PEP to a little over 1,300 patients. We have jump-started, that is, provided HIV treatment at the moment of diagnosis for 210 patients. And our PrEP initiation, which is not yet at all of our clinics, but is at 5 of our 8 clinics, we have initiated PrEP almost 800 PrEP starts. The other thing about these data is that you can see that most of the patients that we've served are persons from groups that are disproportionately affected from HIV, namely Blacks and Hispanics. So other strategies that I'm going to mention very briefly, launching PrEP and PEP delivery systems in New York City, and to support priority populations with novel sex-positive strategies. This is just a quick snapshot. This is looking at 602, a sample of ambulatory care practices, looking at PrEP prescriptions over time from 2014 through mid-2016, looking at PrEP prescriptions per 100,000 patients. You can see from this green line that there's been increasing PrEP uptake for male patients. This red line is a line for female patients, and obviously this is a place where we are going to be focusing some effort. In terms of novel marketing strategies to engage priority populations, we have the Bear It All campaign. For those of you who've seen my colleague Dimitri Daskalakis present, he is also imaged on the Bear It All campaign. This also ran in the subways, and this was a way of getting a message across, particularly to our priority populations, but to all New Yorkers, that it's critical that when you talk to your doctor, you need to be able to talk to your provider about everything about you, and that includes your sex life. And if you're not feeling comfortable talking about your sex life with your doctor, then maybe you need a new doctor. And so our city operators are available to help people find doctors that are appropriate for people in priority populations, namely the LGBT population, but really for anybody. And so we wanted to make the dialogue much more open. Other strategies is we are providing incentive payments for homeless HIV-positive patients to keep their viral loads undetectable and to make the city's health system status neutral. That is, again, no matter who you are, there is some HIV message or service that you may need to consider. This was just released yesterday, as a matter of fact. This is our updated HIV care continuum data for 2016. And you can see that of the 100% shown there as the estimated HIV-infected population, we really believe that our data suggests that 95% of those have been diagnosed, 88% are retained in care, 82% are on antiretrovirals, and at this point, 76% of HIV-infected New Yorkers are virally suppressed. So in conclusion, with 2 minutes and 20 seconds to go, we have an epidemic that we are proud to say, through the dint of hard work, is on the decline. We have taken a multi-pronged approach to systematically eliminate disparities and decrease HIV incidence and prevalence by improving viral suppression, getting the word out that U equals U, undetectable being untransmittable, and improving access to PrEP and to PEP. We're seeing movement towards our goals after a single year, and our next steps include completing our implementation and to do rigorous evaluations so that we recognize that there are areas in the world that are less resourced, so that in a modular way, different programs can look at the cost effectiveness of implementing various pieces of what we've done. So some lessons: dream big. The scientific world and the community advocacy world working together really can move political will. And to take risks, to treat HIV as the emergency that it is, and to think of the world in a status-neutral way, especially within sexual health settings. This kind of approach can potentially have important population impact. Thank you all.